You find a client hunched over with shortness of breath and wheezing. This is an asthma exacerbation. The NCLEX loves a test on asthma because it's all about the airway. I'll teach you what you need to know for NCLEX. So what is asthma? It's a chronic lung condition that causes episodic airway inflammation. This is like having a hypersensitive airway. Anything that gets into that airway that it doesn't like, it gets angry. So what makes this airway angry? Well, common triggers are infection, smoke, dust, and pollen. What happens when this airway gets angry? Well, it secretes a ton of mucus and it does two important things. It bronchospasms, which is tightens those airway muscles, and it creates a lot of inflammation. This all causes that airway to get super narrow, and it's like trying to breathe through a tiny straw. It's really tough. This leads to airway obstruction. So risk factors for asthma include smoking exposure, as well as allergic diseases such as eczema. So what do these clients with asthma look like? Well, they will have feelings of chest tightness. Remember from that bronchospasm. Then they'll have our first star point, our hallmark sign of asthma, wheezing. Remember from those narrowed airways, when air passes through, it causes a wheezing type sound. But when we suddenly hear a cessation of wheezing, that means no air is going through, and that's a concern for a respiratory emergency called silent chest. So look out for that. Then we'll see them in tripod positioning because they're trying to expand their lungs to breathe better, and we're seeing retractions. They're trying to suck in the air through that tiny straw, and that causes them to use their accessory muscles and leads to retractions. Remember, these clients are having trouble breathing, so they're also going to have trouble talking. So they're only going to talk in 2 to 3 word sentences. And our infants and young kids who can't talk at all, they're going to be just irritable and inconsolable and crying a lot. So when we see these findings, we got to do something right away, or it could lead to serious complications such as respiratory failure. That's when there's not enough oxygen getting to that blood, causing hypoxemia, and not enough CO2 being blown off, and that causes hypercapnia. Then we could also see something called status asthmaticus, is when asthma is not responsive to those rescue meds, and that's an emergency. So our first NCLEX quick check. What breath sound is a hallmark sign of asthma exacerbation? Well, that's that wheezing. Remember, that angry airway gets really narrow, and when air passes through, it creates a wheezing sound. So the NCLEX loves a test on asthma teaching, so we need to teach them all about using a peak flow meter and using that peak flow meter to help follow that asthma action plan. Then we need to avoid triggers to prevent an exacerbation and take medications as prescribed. So our peak expiratory flow meter, that's a handheld device used to measure the speed of forced exhalation. That E in peak, think E means exhale. Then this peak flow meter gives us a peak flow rate. And over time, that baseline peak flow rate is our personal best value. So when we tell clients to take their peak flow rate every day, we want them to compare it to their personal best, because that can help determine if they're having an exacerbation before symptoms even occur, and that can help guide their actions in the asthma action plan. So how do they use this peak flow meter? Well, they need to slide that arrow to the bottom, and they need to take a big breath and exhale forcibly and quickly into the peak flow meter. Then they need to record the highest of the 3 attempts. Remember, not the average. So once they get their peak flow rate, this will help determine what they do in their asthma action plan. So that peak flow rate can fall into one of 3 color zones, and these color zones are like a traffic light: green, yellow, and red. So when they fall into the green zone, think good. No changes are needed to the regimen. They don't need to do anything. Yellow means caution. They need to take that rescue medication, and they need to contact their healthcare provider. They may need to change their medications. Then red means danger. They need to take that rescue med right away and seek emergency help. They also need to seek emergency care if they do not improve after taking the rescue medication, or if they have signs of severe respiratory distress, like profuse sweating or refusing to lie down. So NCLEX quick check. Do you inhale or exhale into that peak flow meter? Remember that E in peak is E for exhale. So we exhale into it. Should the client record the highest or the average of the 3 peak flow meter attempts? Well, the highest, not the average. What should a client do if a peak flow meter rate is in the red zone? Remember, red means danger, so we needed to have them take their rescue medication and seek emergency care. So to prevent an asthma exacerbation, we need to avoid anything that can make that airway angry, and that includes avoiding those triggers. So the NCLEX may try to trick you and tell you to teach caregivers to sweep daily. We don't want them to sweep because that can reintroduce allergens like pollen and dust into the air. Instead, they should be wet mopping and using air filters. They also need to close windows when the pollen count is high, and clients need to avoid all kinds of smoke exposure like people smoking or campfires. Then these clients need to prevent infection by getting their pneumococcal and annual flu vaccines. Medication teaching is really important for asthma control. So these medications are prescribed in a stepwise approach based on asthma severity. So if they need more coverage, they need to go up the stairs. And if they are doing better, their asthma is well controlled, they go down the stairs. The NCLEX may ask you about these two main categories for asthma meds, so pay attention. Rescue medications are for asthma exacerbations. These are things like albuterol. Then we see maintenance medications for long-term asthma control, things like montelukast. So remember those two main features of that angry airway. It bronchospasms and gets inflamed. We need to treat that bronchospasm by bronchodilating. We can do this with our short and long-acting beta agonists like albuterol and formoterol. Theophylline is also used for this, and it has a narrow therapeutic range, so we need to monitor for signs of toxicity like vomiting and dysrhythmias. Then we need to address that inflammation by decreasing inflammation with those anti-inflammatories, like inhaled corticosteroids like fluticasone and budesonide, and then our mast cell stabilizers like cromolyn sodium, and our leukotriene receptor antagonists like montelukast. So this is our next start point. We want to use albuterol always first for asthma exacerbations. That A for albuterol, think A is the first letter of the alphabet, so we give it first. Why do we use albuterol? Because it's a short-acting beta agonist, so it works really quickly to open those airways, and it also helps improve delivery of subsequent medications. We also teach do not give long-acting beta agonists alone for asthma exacerbation. Remember, these are long-acting beta agonists, so they're slow to bronchodilate. Therefore, it can increase risk for complications and death. So our next NCLEX quick check, a client has dust and pollen allergies, and the mother asks, how do I prevent my child's asthma attacks? Well, they need to wet mop, use air filters, and keep windows shut during high pollen counts. Remember, no sweeping. The client should take their formoterol inhaler for an exacerbation. True or false? Remember that formoterol is a long-acting beta agonist, so definitely false. For asthma exacerbation, we need to give medications to address those two big things of the angry airway, that inflammation and bronchospasm. Then we need to also monitor for worsening respiratory distress. So number one priority, we want to give something to bronchodilate quickly, something like that short-acting beta agonist like albuterol. Remember, A is at the beginning of the alphabet, so we give it first. Then we can give oxygen if their pulse oximetry is less than 90% or hypoxemic. Then we can also give systemic corticosteroids, and remember to address that inflammation, IV or PO, something like methylprednisolone. Then we need to monitor for worsening respiratory distress. We need to do a chest x-ray to check those lungs. We need to see if there's any kind of infection that could have triggered an asthma exacerbation. Then we also need to take ABGs. These will let us know if there's respiratory acidosis, which is a sign of respiratory failure, things like hypercapnia and hypoxemia. Notify that healthcare provider and prepare for intubation if you see any signs of impending respiratory failure, and that includes paradoxical respirations, which is when the chest moves the opposite of normal breathing, or if you see sudden silence. Remember, the NCLEX may try and trick you and say suddenly stopping wheezing can be a good thing. No, because suddenly stopping wheezing or having no breath sounds means there's no airflow, and that's that silent chest. That's a respiratory emergency, and you need to call that healthcare provider right away. So our last NCLEX quick check, what medication should the nurse give first during an exacerbation? Well, that's that albuterol. Remember, A is at the beginning of the alphabet, and that short-acting beta agonist works really quickly to bronchodilate that angry airway. Then what should the nurse do if a client suddenly stops wheezing? Remember, that's that silent chest. Not a good thing. We need to notify that healthcare provider and prepare for intubation. There is no air going through that airway. Now you know how to master asthma on the NCLEX.